Hi everyone. Thank you for joining me today. My name is Tina Varghese. I'm one of the general cardiologists at Piedmont Atlanta, and today I'm going to spend a few minutes discussing strain echocardiography for our sonographers. Our Piedmont Strain Task Force met recently, decided on a strain acquisition protocol that we'd like to implement throughout our Piedmont sites, and we will be reviewing that right now. Let's start with a review of strain. What is strain? It is a term that we use to describe LV deformation due to an application of a force. It is a unitless measurement that is described as a fraction or a percent, and it uses our current B-mode echocardiography for its calculation by using the speckles within our echo to determine strain. The equation for strain is listed here, and essentially what strain calculates is the change in position from time 0 to time 1 over time 0. So for example, if you start at 10 centimeters and you go to 8 centimeters, it's 8 minus 10 over 10, and you have a strain of negative 20. Likewise, if you go from 10 centimeters to 12, your strain is 12 minus 10 over 10, positive 20 is your strain. The rate at which this change occurs is known as your strain rate. There are three types of fibers in the myocardium: longitudinal, radial, and circumferential. Longitudinal fibers can shorten or lengthen. Radial fibers can be thinned or thickened. And circumferential fibers can rotate clockwise or counterclockwise. All three contribute to the systolic function of the heart. At this time, we have our most robust and reliable data for longitudinal strain, and that is why you will see longitudinal strain used most often in clinical application. So why do we use strain? What is useful about it? Well, just like we get EF for all of our echoes as a marker of LV systolic function, strain is actually more sensitive and more reproducible than EF for systolic function. And for those reasons, it can serve as a marker of subclinical LV dysfunction and an early marker of cardiotoxicity and cardiomyopathy. So the goal here is to try to move from the right part of this arrow to the left. For instance, we see many patients in clinic who present symptomatic with reduced LV function, and at that point you're trying to salvage as much of the myocardium and their quality of life as possible with different therapies. What's better than that option would be to move to the middle, where we catch these patients before they have symptoms but signs of LV dysfunction on echo, which we do often now since we get echoes quite frequently for various reasons. But even more optimal than that would be to catch the patients who don't have symptoms, don't have signs of LV dysfunction by EF or by visual assessment, yet there is some warning sign that there may be challenges ahead due to the acquisition of strain. And that is the goal that we hope to accomplish by incorporating strain into our echoes. Strain can be useful in essentially every branch of cardiology. There are data to suggest it has diagnostic and prognostic implications. Probably the area you will see strain discussed the most in the near future will be in cardio-oncology, as that's where we have the most evidence for its utility. One trial that I think is important for you to know is called the SUCCOUR Trial. It was published earlier this year. The SUCCOUR Trial is important because it is the only prospective randomized controlled trial we have to date that assesses strain. Essentially what it looked at, it took 300 patients with cancer, primarily breast cancer, who were all treated with anthracyclines. These patients had at least one risk factor for cardiac disease such as hypertension or diabetes, and they divided these patients into two arms: the EF-guided arm or the strain-guided arm. And what they looked at was the patients who dropped their EF and were started on cardioprotective therapy, such as beta blockers and ACE inhibitors, were compared with the patients whose strain was dropping and started on such therapies. And then at the final visit, their EFs were recalculated. And what they found was that in patients who who were in the EF-guided arm had a more significant reduction in EF at the end of their follow-up of 1 year despite receiving cardioprotective therapy, while the GLS-guided arm had slightly less than 3% reduction in EF. And so this suggests that earlier detection of LV systolic dysfunction and potentially starting therapy earlier can improve cardiac outcomes. We will need more data and more trials, and I think those will be coming, but this is very promising that strain can be used as a surveillance tool in chemotherapy patients. So with that data in mind, our task force met and decided we wanted to incorporate strain throughout our Piedmont system. And to do that, first we had to answer, well, what are we calling normal and abnormal strain? You can see on the table here that between the different vendors, there is a variation in what is considered normal strain. Generally speaking, the American Society of Echocardiography says somewhere within the range of negative 20 is considered normal. And to be a little bit more of a sensitive marker, we decided that we would call negative 18 or more negative than that as normal. And that terminology can be a little confusing with the negatives and positives, but essentially negative 18 is our cutoff for normal. Any number that is more positive than negative 18, such as negative 12, negative 10, would be considered abnormal, or any reduction in strain in a consecutive echo on the same patient greater than 15% is also considered abnormal. It's also important, due to this variability in the vendors for various reasons, different algorithms, different software analysis programs, different equations for their strain calculations, different parameters. For those and other reasons, it is important to use the same vendor for each patient when you are doing serial strain monitoring, just to take out that one variability. So who should we acquire strain on? Ideally, everyone. But right now, as we try to implement strain, optimize our acquisition of strain, we'd like to focus on 4 subgroups of patients that I'd like you to attempt to get strain on when you see that they're presenting with the following conditions. 1, chemotherapy, as we just discussed. So anyone who is about to start chemotherapy needs a baseline echo with EF and strain. Anyone who's undergoing chemotherapy for surveillance, as we saw that monitoring that could be helpful as shown in the SUCCOUR trial, and anyone who's recently finished chemotherapy sometime in the last 6 months should get strain. Anyone with moderate or severe LVH or increased wall thickness should get strain, as global longitudinal strain and the bullseye plot that we can get from the global longitudinal strain may help us differentiate the etiology for why a patient has increased wall thickness. Is it true LVH? Is it athlete's heart? Is it some sort of infiltrated disease or glycogen storage disease, for example? Anyone who has a speckled myocardium that you're suspecting amyloidosis should get strain. So if you're performing an echo and you notice thick walls, speckled myocardium, biatrial enlargement, a small pericardial effusion, and you're starting to think, does this patient have cardiac amyloidosis? Go ahead and get strain, as it's just giving you more data that might lead you and the clinician towards a diagnosis that may otherwise not have been suspected. And finally, in patients with moderate or severe aortic stenosis, please try to acquire strain. There are data suggesting that in all sorts of valvular heart disease, AS, AR, MR, that strain can offer prognostic information. The most data we have right now is in aortic stenosis, where we've seen that patients with severe AS who are referred for AVR, those who have reduced strain actually have increased cardiac morbidity and mortality. So while this is not part of our current guidelines in terms of using strain as a criteria to refer patients for aortic valve replacement, I wouldn't be surprised if this was incorporated in the future, because we are seeing that reduced strain in valvular heart disease can portend a poor prognosis. So these are the 4 patients we'd like you to absolutely try to obtain strain on. Just some points on image acquisition. You will be getting your apical 2, 3, and 4 chamber views, and it is recommended that you do this consecutively to reduce any fluctuations in heart rate. And once you acquire your apical 2, 3, and 4 chamber LV views, then you will be able to average them to a global longitudinal strain value and get a bullseye plot. What the reader or the physician should see in your echo images is a video acquisition of the tracking of those 3 apical views, so they too can confirm whether they agree with the tracking of the strain. The strain curve should be shown so we can see if strain is being tracked appropriately, and to look for any regional issues with strain. And the global longitudinal strain and the bullseye should also be shown. Strain needs some sort of time reference to measure from start to finish. So it's always done from end diastole to some part of systole, and different vendors may have different default parameters set, like peak systole or end systole or peak systolic strain. And so it is important that we are unified in what we set our time point to. So as the task force discussed, we decided to be consistent with most of the guidelines, which recommend end systole. So please make sure you're set to end systole. Likewise, you can measure strain either the endocardial border, the mid-cardium, or the epicardial border. Once again, for consistency's sake and to be consistent with our guidelines, we are recommending everyone measure strain at the endocardial border. It is also believed that longitudinal fibers are most present in the endocardium, and since this is longitudinal strain we're acquiring, it makes sense to focus on the endocardial border. Of course, it's important to optimize your image quality, optimize the frame rates, and reduce foreshortening when you are getting these images. Your frame rate should be somewhere approximately 40 to 80 frames per second. Any lower than that, you start losing the speckles and losing the accuracy of your strain, and too high of a frame rate can make your signal quite noisy. So it's important to optimize your frame rate, reduce any foreshortening so that you do not cut out your apex. It is believed that the apex actually has higher strain values than the base, and so reducing foreshortening is important so that you don't underestimate your strain. There will be a separate video or videos provided to discuss vendor-specific acquisition of strain, but the aforementioned pointers should be applicable to everyone. And finally, as mentioned in the ASC 2015 chamber quantification guidelines, quote, when regional tracking is suboptimal in more than 2 myocardial segments in a single view, the calculation of GLS should be avoided, end quote. So if you are unable to get all 3 apical views and the images are just difficult, then our plan is to try to show just the apical 4-chamber view alone for simplicity's sake. So if you can get a 4-chamber view and a 2-chamber but not a 3-chamber view, for example, don't bother averaging the 4 and the 2-chamber. We just won't calculate global longitudinal strain if you can't get all 3 apical views, and then only document your apical 4-chamber view. So the goal is to get all 3. That's the optimal situation. Show the longitudinal strain globally, show the bullseye plot, but if that is just not feasible, then at least try to show just the apical 4-chamber view alone. There are some data to suggest that even just the 4-chamber view alone can be useful in monitoring patients. If you cannot get strain in any view despite multiple attempts, try 3 attempts, and at that point please just include a picture or video of your attempt of the strain so that the reader is aware that you attempted, and you can label attempt or label attempt times 3, and at that point please move on so you don't spend too much time trying to attain something that we just may not be able to get in that patient. Here is an example of a strain using our Siemens site vendor in our Piedmont site. It may look different between the different vendors, but I just wanted to give you an example. So here you can see a 2-chamber view with the tracking of the endocardium. The strain is actually written here, and it is important to know with your vendors where the longitudinal strain is shown, because there may be other numbers shown such as segmental strain and so on, and so it's important to find where your longitudinal strain is shown, which is right here in our Siemens platform. Here you can see the segmental curves, and they should line with your QRS, and so in systole the longitudinal fibers shorten like we discussed earlier, and so should get more negative, and then they relax and get more positive in diastole, so on and so forth. Since in this video it's quite hard to see the endocardial border tracking, the sonographer provided an additional clip that zoomed in on the 2-chamber view and shows the attempt at tracking the endocardial border to the best of our ability, which the reader can then follow to see if they agree with that tracking. This should be repeated again, and these images acquired for the 3-chamber view. And once again, the strain in our platform is written here. You can use the strain curves again. Make sure you agree with the tracking. Look for any regional deformation. And finally, again, in the 4-chamber view, same thing. Strain curves, strain value, and endocardial border tracking. Now, some vendors may give you the global longitudinal strain number averaged already in a separate window, and that's great. That makes our jobs easier, and all we have to do is input that number into SINGO or into whatever reporting modality you have. With our case here, the individual strain numbers are shown but not averaged, and so under SINGO, we have a separate option in the LV tab under the worksheet where you can put in all 3 different strain numbers. It'll calculate for you an average strain that can then be typed into global longitudinal strain, and that way you don't have to manually calculate this. If you are unable to get all 3 views and you can only get a 4-chamber view, for example, you have the option just to put that 4-chamber view here. I would recommend, when we talk about strain vocally, we sometimes may talk in terms of the absolute number and may just say strain is 17.6, but when we annotate, it will be important to include the sign so that there is no confusion over whether this is a negative or positive value. So I would include a negative here to show that the strain is actually negative 17.6. Finally, make sure you include a clip of the bullseye plot, and depending on the color scheme offered by the vendor, it may be easier or more challenging to look for the pattern recognitions that you can see in certain cardiomyopathies, but I would still include the bullseye plot. We can still look at the numbers and see if there's any pattern that looks obvious to us. Here are some examples. This is a patient who has cancer, who before pre-treatment with an anthracycline had a normal EF of 60%, and you can see their bullseye plot with the global longitudinal strain was all red. Red indicates negative numbers, blue indicates positive, and this patient had a beautiful bullseye plot of all red strain of negative 21, which is normal. After several months of treatment with an anthracycline, you can see that there is a change in the appearance of the bullseye plot. The red is no longer as vibrant as before. It's almost a light red with a pink incorporated. The EF, though, if you look, was reported the same, 55 to 60. But what is different is that the strain calculation is not only abnormal, but it is less than our cutoff of 18, and it is a greater than 15% reduction from baseline. So this is an example of a patient whose strain should perk your ears to considering whether they have cancer therapy, chemotherapy-related cardiotoxicity, and should initiate a dialogue between the cardiologist and the oncologist on optimizing this patient further to reduce any more cardiotoxicity. Here is an example of a patient with diffusely abnormal strain, as you can tell just by the color scheme alone and by the numbers. There's even a blue or positive area of strain here. And you can see the strain is worse in the basal septum. This is an example of hypertrophic cardiomyopathy. And in this example, the patient has normal strain in the base segments, but quite abnormal focused in the apical segment. This is apical hypertrophic cardiomyopathy. Here, there is apical sparing, where the apex is normal, but strain is abnormal everywhere else. And this is a patient with biopsy-proven cardiac amyloidosis. This sign of this kind of target sign or apical sparing sign should alert you to amyloidosis. And this patient a year later still maintains that strain pattern on their bullseye plot. So it's quite fascinating how using a modality that we already have and use every single day, we can extract data that shows us additional patterns that can lead us to varying diagnoses. You can almost think of it like cardiomyopathies have their own fingerprint, and this is you finding that fingerprint with the bullseye plot. Some pitfalls to avoid. When you are tracking the LV, please make sure you do not accidentally track the papillary muscles. You can see in this example that doing so caused a peak systolic strain of negative 19, when in actuality the peak systolic strain was negative 28. Likewise, please make sure that you don't track all the way into the atrium. The tracking should end at the annulus, where the leaflets of the mitral valve are inserted, and so coming up into the atrium caused this significantly abnormal basal infraseptal strain pattern that, when corrected, looks much more normal now. And finally, it may be challenging in your 3-chamber view to avoid that LVOT or aortic root, but again, pay attention to where the base of your LV is and make sure to stop the tracking there. As you can see that this caused a change in strain from -15 to -19. So be aware of the other structures that can make your strain value less accurate and less reliable. Now let's review some questions that have been brought up. Should strain be done in patients with a prior history of chemotherapy? That's a good question. What we discussed was performing strain on any patient who is about to start chemotherapy or undergoing chemotherapy. That is quite important because that is the patient that we can probably do the most good for in terms of surveillance. Now, with regards to how long to monitor after chemotherapy, there's not a lot of data out there. Part of the reason for this is a lot of our oncology trials did not incorporate cardiac imaging, and so there's a lot of fluctuations, and it's very much a gray zone of how exactly to monitor. But there are some guidelines that actually recommend for certain chemotherapy agents to get every 6-month echoes for up to 2 years. So a shorter answer to your question would be yes, get strain if you can on any patient with a history of chemotherapy, as you don't know if this is something that still needs recurrent monitoring or if they are unfortunately needing to restart treatment, you have a new baseline. So if you are able to get the windows, go ahead and get it on these patients, but remember at bare minimum to get strain on patients who are about to start chemotherapy or actively undergoing chemotherapy. Should strain be done in patients with elevated blood pressure? Yes. If the patient who is coming for an echo has strain ordered for them, or you see that they fall under one of our 4 categories, please obtain strain. Strain is load dependent, meaning it is sensitive to your preload and your afterload. Elevated blood pressure is associated with reduced strain values, and that is why it's important, as we do with our routine echoes anyway, to incorporate heart rate and blood pressure into the echo report that the clinician can then use in conjecture with the findings of the echo to decide best clinical management. If the clinician thinks that the highly elevated blood pressure values are the reason why the strain is abnormal, then they can decide to optimize the blood pressure and bring the patient back for strain if necessary. Should strain be done in patients with arrhythmias? Arrhythmias do make strain acquisition complicated and sometimes not possible. If you have a patient with AFib and rapid ventricular response, truthfully, you may not be able to get strain on those patients. There is some potential with some vendors to get multiplane acquisition, and you see this a lot with 3D strain, where a multiplane acquisition can give you all the planes of strain with one beat, and that might be a solution. Unfortunately, right now, 3D strain is not something we use in clinical practice yet due to its lower spatial and temporal resolution, but that may be something that comes in the future. And if you have a patient with a lot of PVCs, try to wait till those PVCs quiet down and you can get 3 beats in a row without PVCs to get your strain. With AFib, if you can find an area in AFib where the R interval is consistent, use that. But again, if the rhythm is just not letting you track strain or get your bullseye, then again, just show that the attempt was made, and that we will understand that. If the apex is not well visualized and does not track, should we process strain? So again, the LV is divided into 6 segments, the base, mid, and apex on the right, and base, mid, and apex on the left. And if you are able to get most of the segments, yes, go ahead and process strain. But if 2 or more segments are missing, apex or otherwise, then we should not calculate strain in those patients. What should be reported if 2 or more segments do not track in any of the apical views? If 2 or more segments do not track, then a statement should be written along the lines of unable to obtain strain due to suboptimal tracking. If only reporting apical 4-chamber views, should bullseye still be required? No, if we're only reporting one apical 4-chamber view, there is limited utility to bullseye acquisition, as you need all 3 chamber views in order to get the full bullseye for pattern recognition. So in that case, just report the 1 apical 4-chamber view. Our writing committee is working on statements that can be utilized in our report. For example, along the lines of global longitudinal strain is X, or apical 4-chamber strain is Y, and that's where we will incorporate those numbers. Should circumferential strain or radial strain be done? At this time, there is limited clinical utility to circumferential and radial strain just because the data is not there yet. I think in the future it will only be a matter of time before we incorporate all the fibers of the heart to make a more thorough assessment of a patient's systolic function. But because longitudinal strain is what we are using clinically, our expectation is just that you try your best to obtain longitudinal strain in all your patients. Some sites have been doing circumferential strain, and if you want to continue doing that just for practice sake and for your interest, by all means go ahead. But the expectation right now is for us to try our best to acquire longitudinal strain on as many patients as we can, get comfortable with getting good images for strain, tracking strain, optimizing our acquisition so that we stay on par with our guidelines and with the trials that are coming out. And then as more information comes out about the other strain modalities, we will be ready to adopt them as well. So in conclusion, just a reminder that strain increases the sensitivity of cardiac ultrasound by detecting early changes in ventricular function. As a result, it can predict subclinical LV dysfunction and progression to heart failure. It will almost certainly become more routine to see strain in everyday echocardiograms for multiple indications, and so I can't emphasize enough the importance that we get comfortable with this modality and work together to make this commonplace in our echocardiograms. And in order to do that, practice is key. Thank you for your time. Thank you for all that you do, and I hope that you found this session informative. Thank you.